Hi everyone, my name is Margaret Strickland and I'm here with my peers Caroline Benson and Martina Travis. We are second-year nurse anesthesia students at Penn, and we are excited to talk with you about evidence-based practice for monitoring patients at risk for opioid-induced unintended advancing sedation and respiratory depression. Our hope is that with this education, you will have a better understanding of opioid-induced advancing sedation and respiratory depression and feel empowered to make a change in your practice. Hopefully, the knowledge you gain from these 4 weeks of education will encourage you to advocate for your patient safety and begin monitoring with continuous capnography based on your risk assessment. What % of patients receive opioids? More than half of hospitalized patients receive opioids, and up to 8 million Americans are on long-term opioid therapy. How many hospitalized patients will experience an adverse event from opioids, including death? 5 out of 100 of hospitalized patients receiving opioids will experience an adverse event, including respiratory depression, that leads to death. This is why we are here to talk with you today about opioid-induced respiratory depression and the need for a standard of care in monitoring practices to decrease opioid-related adverse respiratory events. The objectives of this presentation are to examine the significance of opioid-induced respiratory depression, OIRD, discuss the American Society for Pain Management Nursing guideline recommendations, and identify risk factors for opioid-induced respiratory depression. Opioid use and overdose have reached unprecedented levels around the world. In the U.S., remediation of pain is one of the most common reasons adults seek healthcare. So it is important that we, as healthcare providers, are educated on opioid policy interventions and balancing analgesia with patient safety. Dosing opioids to achieve acceptable pain levels without appropriate monitoring has led to a concerning increase in adverse events caused by opioid-induced advancing sedation and respiratory depression. These respiratory events are significant and lead to over 50% increased length of hospital stay and a 3.4 times greater risk of mortality. All patients receiving opioids are at risk, especially patients in the 24-hour postoperative period. With this continuous rise in adverse events, greater vigilance in monitoring for opioid-induced respiratory depression has been recommended. What is the difference between opioid-induced unintended advancing sedation and opioid-induced respiratory depression? Opioid-induced sedation refers to a disordered level of consciousness. It can range from an oriented patient to one with complete loss of consciousness. It is important to realize that unintended advancing sedation often precedes opioid-induced respiratory depression because as level of consciousness decreases, respiratory drive also decreases. Opioid-induced respiratory depression is a decrease in the effectiveness of an individual's ventilatory function after opioid administration. In the clinical setting, opioid-induced respiratory depression is usually described in terms of decreased respiratory rates, less than 8 or less than 10 breaths per minute, decreased oxygen saturation levels, or increasing levels of end-tidal CO2. End-tidal CO2 measures the level of exhaled carbon dioxide. Nurses can prevent adverse events related to respiratory dysfunction and reduce morbidity and mortality with proper respiratory assessment and early recognition and intervention when patients demonstrate signs of deterioration. Although opioid therapy can lead to adverse events such as respiratory depression, opioids are an essential component of pain management, so it is necessary that you are adequately monitoring your patients for opioid-induced respiratory depression. It is a delicate balance between achieving optimal analgesia and avoiding respiratory depression. Erring on either side has its consequences. Both inadequate pain management and opioid-induced respiratory depression can lead to longer hospitalization and rehabilitation, cardiopulmonary morbidity, readmissions, and increased cost. Our project purpose is to design and implement a nurse education program to accelerate the uptake of evidence-based practice guideline recommendations on monitoring for opioid-induced respiratory depression and unintended advancing sedation. The first step to achieving safe and effective monitoring practices for opioid-induced respiratory depression is to increase nurses' knowledge of it. Increased knowledge of OIRD will lead to implementation of evidence-based monitoring practices recommended by the Joint Commission and by the American Society for Pain Management Nursing that promote early nurse identification, proactive intervention, and ultimately improve patient safety by preventing adverse respiratory events. Our project aims are based on the ASPMN evidence-based practice guideline recommendations. Through this project, we hope to improve nurses' knowledge of the best monitoring practices and of patient risk factors for opioid-induced respiratory depression, to determine nurses' compliance with the evidence-based practice guidelines, and to improve patient safety through early nurse recognition of adverse respiratory events. The American Society for Pain Management Nursing released updated monitoring guidelines in 2020 based on the most recent Joint Commission recommendations for monitoring for opioid-induced respiratory depression. We will briefly review these 12 recommendations and their implications for practice. The first recommendation is that pain management strategies should be individualized and aligned with the Joint Commission recommendations. Since all patients receiving systemic or neuraxial opioids are at risk for opioid-induced respiratory depression, it is necessary that nurses complete a thorough assessment of patient risk factors for OIRD. This individualized assessment should occur before administering opioids and should be continually reassessed as part of your scheduled nurse assessments over the course of your patient's hospitalization. Comprehensive patient risk assessments require you to communicate your patient's risk for OIRD among the multidisciplinary care team and at times of care transitions, such as handoffs or shift change. Nurses play a critical role in identifying patients at risk and developing and implementing plans of care to adequately assess and monitor high-risk patients for opioid-induced respiratory depression. Through increased frequency of nurse assessments and implementation of continuous electronic monitoring for high-risk patients, nurses can prevent serious adverse events secondary to unintended advancing sedation and respiratory depression resulting from opioid therapy. Risk factors for OIRD fall into three categories: individual patient risk factors, pharmacologic risk factors, and iatrogenic risk factors. Individual risk factors are defined as factors that predispose a person to unintended opioid-induced advancing sedation and respiratory depression. Specific patients should be monitored more closely than others for opioid-induced respiratory depression due to their independent patient risk factors. Individual risk factors include patient characteristics, comorbidities, the type of anesthesia, and type of procedure. Factors which contribute most to adverse respiratory events include cardiopulmonary disease, age greater than 65, BMI greater than 30, and an ASA score greater than 2. If a patient has 2 or more of these risk factors, they are considered high-risk patients. Over the past several years, there has been heightened awareness on the links between obstructive sleep apnea, opioid-induced advancing sedation and respiratory depression, and sudden death. This has subsequently prompted the practice of screening for OSA on admission. Although potentially helpful in reducing adverse respiratory events with opioids, the practice of assessing and increasing monitoring for only those patients with OSA does not address the full extent of the problem. All patients with risk factors for opioid-induced respiratory depression should be assessed for increased monitoring. Certain comorbidities put patients at higher risk than others. Patients identified as high risk include age 65 or older, obese and or morbidly obese, pre-existing cardiopulmonary disease, documented risk of obstructive sleep apnea, and all patients on IV PCA. Individual patient risk factors should be considered by educated providers when determining monitoring methods and monitoring frequency. To prevent adverse respiratory events, appropriate electronic monitoring methods, including utilization of continuous capnography and continuous pulse oximetry, in addition to frequent informed nursing assessments, are necessary for high-risk patients. In addition to individual risk, consideration of pharmacologic risk of opioids is essential in delivering safe care. Nurse knowledge of the medications they administer and their effects on patients is important in preventing synergistic adverse events and administration of contraindicated medication. To minimize patient risk for respiratory depression, a multimodal approach using opioid adjuncts and alternatives should be used with high-risk patients. Multimodal analgesia can include acetaminophen, nonsteroidal anti-inflammatory drugs, gabapentinoids, and ketamine to achieve adequate analgesia while reducing opioid requirements. Knowledge of patients' opioid tolerance is another key component to safely administering opioids. Opioid-naive patients are those who have not used opioids in their medication history. Being an opioid-naive patient puts them at increased risk due to their increased sensitivity to opioids, which can result in hypoventilation and airway obstruction. Opioid-tolerant patients have minimal risk for OIRD due to their tolerance. However, patients on chronic opioids can be considered at high risk under 3 conditions. When the opioid dose is increased significantly above a patient's maintenance dose, when the patient is switched to a different opioid class, and when an additional sedative medication is added. It is essential that nurses understand the peak effect times of the opioids administered, recognize that patients are at highest risk during drug-specific peak times, and nurses should then complete additional respiratory and sedation assessments at those times. An environment that facilitates effective multidisciplinary communication, provides adequate staffing ratios, and enables purposeful hourly rounding by nursing staff is imperative. All hospitals are not conducive to continuously monitoring all patients receiving opioids. This emphasizes the importance of nurse clinical decision-making in determining the appropriate level of care and monitoring frequency needed for each of your patients to ensure optimal patient safety. Monitoring frequency influences the number of detected respiratory depression events and contributes to improved patient outcomes. Best practice recommends instituting individualized plans of care that monitor high-risk patients more closely by utilizing continuous electronic monitoring in addition to frequent nurse assessments. For patients on PCAs, it is suggested that sedation levels should be performed at least every 2 to 2.5 hours. The use of technology-supported monitoring, however, does not absolve nurses of their responsibility for monitoring their patients' level of sedation and respiratory status. Nurses can help prevent adverse respiratory events by using critical thinking and trending respiratory rate, sedation level, oxygen saturation, and end-tidal CO2 over time. Trend monitoring refers to examining patterns of change in patient monitoring data over time to evaluate if monitoring outcomes are worsening, improving, or remaining stable. Trend monitoring of multiple variables such as respiratory rate, level of sedation, pulse oximetry, end-tidal CO2, and minute ventilation can aid in identification of those patients showing early signs and symptoms of impending opioid-induced unintended advancing sedation and opioid-induced respiratory depression that require immediate actions, including more frequent monitoring, reduction in opioid dose, discontinuation of an opioid, and/or activation of a rapid response team. Various monitoring methods and monitoring frequencies are currently used to monitor for opioid-induced respiratory depression. These include electronic monitoring methods such as pulse oximetry, capnography, and respiratory rate, as well as intermittent nursing assessments. However, studies show that capnography monitoring is the most reliable indicator for opioid-induced respiratory depression when compared to both pulse oximetry monitoring and intermittent nurse assessments. Capnography monitoring, which measures end-tidal CO2, shows post-opioid respiratory depression events earlier than pulse oximetry and leads to early nurse intervention and prevention of respiratory adverse events. Continuous electronic monitoring, including continuous capnography, is necessary to accurately capture adverse respiratory events and should be considered for all patients at risk. Additionally, in case of emergency, all clinicians need to be educated on the use of naloxone. Nurses should be involved in tracking the frequency of and reasons for naloxone administration to better understand factors leading to opioid-induced respiratory depression and contributing to the use of naloxone. The type of electronic monitoring should be appropriate to the condition of the patient, presence of supplemental oxygen or positive airway pressure therapy, the patient's response to care, the patient adherence to monitoring device, and detection capability of the technology. For patients receiving supplemental oxygen, it is recommended to use continuous pulse oximetry and continuous capnography monitoring. With supplemental oxygen, the pulse oximeter will not always display a lower oxygen saturation despite hypoventilation, but continuous capnography can immediately detect a rise in end-tidal CO2, which is a hallmark sign of hypoventilation. This allows for earlier nurse intervention and prevention of OIRD. It is important to be able to distinguish hypoventilation from normoventilation with continuous capnography monitoring in order to detect the early signs of opioid-induced unintended advancing sedation and respiratory depression. With a normal end-tidal CO2 waveform, the respiratory rate is generally between 12 breaths per minute and 20 breaths per minute for adults. The waveform should return to baseline, the frequency should match the patient's respiratory rate, and the height of the waveform should be between 35 and 45 millimeters of mercury, which is the normal end-tidal CO2 reading. In hypoventilation, you have a buildup of carbon dioxide as a result of decreased ventilation. The hallmark sign for hypoventilation is an elevated end-tidal level above 45 millimeters of mercury in the presence of normal perfusion, circulation, and metabolism. Causes of hypoventilation include a decrease in respiratory rate, a decrease in tidal volume, and use of central nervous system depressant drugs such as opioids. The ASPMN recommends that there is continued nursing education on opioid-induced respiratory depression and that hospitals have policies and procedures that support the prevention of opioid-induced respiratory depression through monitoring, patient risk stratification, and education. To summarize the main takeaways, all patients receiving opioids are at risk for opioid-induced respiratory depression. The first 24 hours after surgery and the hours between 12 a.m. and 6 a.m. hold the highest risk for fatal respiratory depression events. Patients with obstructive sleep apnea and other comorbidities are at increased risk for postoperative respiratory depression. Continuous capnography should be used with all patients receiving supplemental oxygen. Trend monitoring should be used to proactively prevent opioid-induced respiratory depression. And interdisciplinary collaboration and communication are necessary to develop, implement, and evaluate policies and protocols to guide safe opioid prescribing, administration, and monitoring. Thank you everyone for listening to our presentation. We appreciate your participation and support in this initiative, and we hope you found this education beneficial.